So now we're going to talk about the AV blocks. And this obviously is a problem in the junctional node, right, between the atria and the ventricle. So there's a block between the atrial cells and the ventricular cells. That makes sense. And beyond the AV node, you have your bundle branches and your bundle of His, or the AV bundle. So really, this is all in your book. It's pretty much, you could memorize, but try to understand it. There's first degree AV block, which sometimes we write like this. Second degree AV block, which has two types. So there's Mobitz type 1, which is, you'll see, is called Wenke-Beck. You'll see the spelling in a minute. And Mobitz type 2. So those are second degree AV blocks. The third degree AV blocks are really complete heart block, where there's no conduction via the AV node. So that's complete heart block. So there's no communication between the atria and the ventricles. So they kind of have to do their own thing. But the SA node is working at this point. It's the AV block. So the ones we're going to look at anyway have a viable SA node and a viable atrial cell action potential, pacemaking potential. So there's a little memorization, but it's all in your lab manual. You can look through that. You see it's laid out, and I'm going to stick to that as much as possible. So this is a first degree AV block, which is the least noxious or the least damaging. And you don't necessarily have to have a artificial pacemaker installed if you have a first degree AV block. Okay, so this one's a little difficult. I wouldn't look at the top one. I would look at the bottom one, only because this one doesn't have a P wave. I just noticed that, but this one does. So the P wave is here, followed by a normal QRS and T. P wave, normal QRS, P wave, normal QRS, P wave, normal QRS. So what do you notice that's not normal on this before you count the heart rate? What do you notice about the P?
PR.
Yeah, the PR interval is prolonged. It's prolonged, but it's consistently prolonged. So this is consistent. So the AV node is holding on to the conduction just a little bit longer than it should be. So greater than 0.2 seconds, which you memorized, right? So I like the bottom picture because I really don't see a P wave. I don't want to throw you off. Okay, so the P waves with prolonged intervals. And now you talk about what's called the conduction ratio. And that is your P to QRS. So if we did that on this particular EKG strip, you'd have 1P, 1 QRS, 1P, 1 QRS, 1P, 1 QRS every time. So this is a 1 to 1 ratio. For every P wave, you have a QRS. So there are no dropped QRSs. So I think you should start here and know the difference between this, normal sinus rhythm, sinus arrhythmia, and junctional rhythm, of course, or atrial rhythm, any other rhythm. So this is a first degree AV block. So I would make sure you know this one first before you can move on. By the way, these have reasons down here, which I guess could help you in the lecture if it need to be, but you don't have to know these causes and treatments for lab. You just have to know what it looks like on the EKG. All right. So this is sinus rhythm in a way. It's starting with the SA node, but it's an arrhythmia because there's an AV block. But we can still say the pacemaking potential is starting with the AV node. And that's a little advanced now, right? So this is second degree AV block, Mobitz type 1. And this is Wenke-Beck. So now we have to take a look again. P QRST, P QRST, P QRST, P dropped beat, P QRST, P QRST, dropped beat, P QRST. Okay, you see what's happening there? So what do you notice about the PR intervals here?
They get longer and longer.
Yeah, progressively, and then it starts again after the missed beat. So there is a lost QRS in this. So it's like we say, I would say this is a 4. I think your book is going to say this too. Sorry. Your book will say this is a 4:3 conduction ratio. Remember P waves to QRSs. So we dropped 1 QRS, and that's a problem. So now we got to think about treating this, right? If you just happen to find this out on an EKG, you might get away with medication, but you don't necessarily, the point is you don't necessarily have to put an artificial pacemaker here, only if it's symptomatic and there are other conditions. Everybody understand this? So this is a 2nd degree AV block, Mobitz type 1, and that's Wenke back. So you do have a drop QRS and you have progressively lengthening PR intervals somewhere within that strip, and it seems to repeat itself too. So it's an AV block, of course, and there's a delay. It's getting through, but it's just a little bit slowed down. This is 2nd degree AV block, again, 2nd degree AV block. This is Mobitz type 2. Not really much of a cute name there. And this is multiple P waves. So in this one, you can have a conduction ratio of 4:1. So 4 P waves to 1 QRS, and you can count them out. What do you notice about this QRS complex? Anybody see anything that you could recall from that? Anyone? What does it look like? Bunny ears. So this is a bundle branch block, don't you agree? On top of the AV block. And if this is V2, would it be right bundle branch block or left?
Right.
Way to go. Way to go. Dan, you got to wake these people up, man. Okay. Mobitz 2, PR interval could be normal, but there's so many P waves and so many lost QRSs. So there's multiple lost QRSs, dropped QRSs. So this is going to be a problem. You can't, this is not consistent with cardiovascular life, so you're going to need a pacemaker for this. So the bundle branch block was just a bonus to this horrible condition of 2nd degree AV block Mobitz type 2. So take a look at this one, and the ones in your book are very helpful. There's tables. Again, I can't. If you have your book in front of you, you can tell me the page if you don't mind. But just like we did last week with the rhythms, the AV blocks have definitions and nice tables to help you remember. So basically, the QRS can be normal. I mean, it is normal in all of these, just like in some of the other rhythms that are supraventricular. But this one just happens to be bundle branch block. So there's multiple things going on. So this one, for Mobitz type 2 AV block 2nd degree, you would need a pacemaker. So now, just to make this simple, this is 3rd degree AV block, and you'll get some practice EKGs, and you have some for this week too. This one, I think the first thing you look at is, again, you have dropped QRSs, you have a change in the ratio. It's a little bit higher. It's not 1:1, obviously. It's not 4:3. It's definitely in between. The PR interval can be normal or it could be random in this one. And of course, it is the PR interval is not normal in many of these beats. Sometimes it's really close, like here. So you got to be careful with this one. So the way for our class, I think the first thing you should notice is the wide QRSs. These are not normal. And then you see the erratic. There are P waves. That's what I think from the first day I told you how to look at these EKGs. Always look for the P wave, because this one you have a P wave. So you can't call this ventricular rhythm. This is not ventricular rhythm. And then you look at each one, well, P wave, and then we have a delay. And then there's a P wave, another delay. And you could have 2 P waves and a loss of well, actually, this is a P wave here, which is hard to see. Really hard to see right here, but I wouldn't do that to you. But there are more P waves than there are QRSs. So this is a complete heart block, where this is why it doesn't look normal. This is why the P wave can come after the QRS again, just like that weird junctional rhythm. But remember, in that weird junctional rhythm, the QRS complex was normal. So you have to decide that you have to know that this is not a ventricular rhythm. You can't call this accelerated idioventricular rhythm. So this is the one you really have to look at. So look at the easiest, not the easiest one, but the most benign one, which is first degree AV block. And make sure you can differentiate this from normal sinus rhythm or sinus arrhythmia. This is a regular rhythm in this case. So read through those charts and tables in your book, and then look at third degree and look at the multiple P waves, the wide QRSs, and our P waves. That's the whole thing. This is complete heart block. Then you obviously you need a pacemaker for those types of hearts, right? You should be comfortable with bundle branch blocks and the rabbit ears. Remember, V1 and V2 is looking at the right side of the heart. V5 and V6 more towards the left side of the heart. So if you see the rabbit ears in V1, you're looking at a right bundle branch block. Remember, R prime, right? R prime. So you got to see that in a few slides in the last PowerPoint. This is called WPW. You may have heard of this in lecture. So this one's kind of subtle. You know, it has this early rise of the R wave, and that's called a delta wave. So it's really subtle. To me, it looks like the sail of a sailboat, you know, right on the mast, kind of coming out a little bit early. P wave is there. It's other than the delta wave, it's a normal QRS. So this is really subtle. You have to look at that. And this usually happens a little early because you have that accessory pathway of conduction. There's no insulation. It's not compartmentalized like it should be. So you have a little early depolarization. So this is WPW, Wolf, Parkinson, White. So take a look at this and compare it to other EKGs, because you might think you see it somewhere else. So always keep this as a baseline just to see what this condition looks like. And again, you don't have to know the treatments or the causes or anything like that for a lab. Although I might tell you the cause because that kind of gives you an idea what you're looking for. Cool. And these are in your book, these SVT, supraventricular, I should say, paroxysmal. Paroxysmal means sudden. Like all of a sudden you have like a relatively, this is ST depression, but you have a normal PQRS, then suddenly you get this ventricular beat, right? Everybody agree this is a wide beat. It's a wide QRS. And it comes out of nowhere, and then it starts up again, back to what it was before. Okay, because the SA node slightly stops for a while. You could have Wolf, Parkinson, White. It could just be incidental or insidious out of nowhere. But paroxysmal means sudden. And then these are normal QRSs, but this, of course, you saw went from possibly a normal heart rate to tachycardia. So supraventricular paroxysmal tachycardia. So now you can see it's not regular, obviously. If you look at the whole strip, you could see relatively normal. Again, there is ST depression, but QRS is normal, more or less. And then you see the sudden ventricular beat, and then it goes off into tachycardia when it returns. Okay. This is, I wouldn't really look at the one in the middle because that's kind of weird. Let's forget about that one for now. This one's throwing me off, this drawing. But here's SVT on top, really close R waves, and they are normal QRSs, even though they look really narrow. So this is where the P wave is lost in the T wave, so it makes the T wave look bigger. It adds to the amplitude of the T wave because the P is inside of it. So remember, from the first exam, we could slow this down with carotid massage vagal maneuvers and see if it's starts, well, actually from last lab, you know it's whether it's going to be a sinus tachycardia or an atrial tachycardia or junctional tachycardia. It could be all three. We don't know. So what do we call it? supraventricular tachycardia. Now, the one on the bottom looks like a regular rhythm, but obviously there's no P wave. It's regular, and you have these alternating negative, positive in this particular strip. It's going negative to positive from left to right, but it could go the opposite way too, and it's going to have the same look. So this is a VTAC, right? This is ventricular tachycardia, which you know is going to be above 140 beats per minute, because this is a ventricular rhythm. And again, just to repeat, what's the inherent cadence of the ventricular cells?
20 to 40.
20 to 40, yeah. So that nobody's going to survive with that. So the sympathetic nervous system kicks in, kicks ass, and tries to get some cardiac output out of the ventricles. But what you wind up with is a dangerous condition like this called ventricular tachycardia. And you know where this is going, right? I mean, you know that this eventually could lead to a fibrillation, as unless the SA node comes back to be working. So this is kind of one you should know what it looks like, VTAC. Okay, now this one you have to look a little closer. And there are some, I'm getting a call from WPNJ. What's this saying?
Announcement from William Patterson University.
You guys getting this?
University offices will open today, Friday, February
Who gives a
25th
crap?
at noon. Classes will continue to be conducted remotely throughout the.
So it's all remote today. That's the idea, right? Yes? Hello?
Yeah.
Did I lose you guys? All right. So let's take a look at this one on top. Again, left to right, you see the cadence, 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 and then it changes right here, right? It changes right there. So this came early, then there's a slight delay, and then it goes back. So this is a premature contraction, and this is atrial. This we don't really say premature sinus contraction, just realize, so it's always going to be coming from atrial or junctional. So this is a premature atrial contraction. And it kind of showed up right in the middle there. So now you have to look at every beat now on the strips, because you got the rhythms down, you got the heart rates down. Now let's see what the other things are. Now this one is normal cadence, normal cadence, normal cadence, normal cadence, and then you got a problem here. And then it goes back to normal. So here's your premature beat. Now tell me what kind of beat this is. It's premature, so it's a P and a C. What letter would you put in the middle there? Anybody? Yeah, that's junctional. Excellent. Way to go. Yeah, because there's no P wave, right? There's no P wave. Now you're on it. Now you're on your game. And it went back, and this could be for no reason. There's my pen. Sorry. Now let's look at the one on the bottom. Normal. Rhythm rate. Normal. Then you got a problem here. Normal, normal. So they have a premature contraction here. And this is, what would you call this one? No P wave, but look at that QRS. I don't like it.
PVC.
That's a PVC. PVC, premature ventricular contraction. And that's the one you'll probably see the most in this class, you know, in your NCLEX, where PVC looks like. So here's the premature atrial contraction. I know we'll never call it sinus, so always just say atrial and you'll be correct. You'll be cool. You'll be cool. Here's a complex. You're going to see like this is going to happen in couplets. Like you'll see a normal and then a PVC, and then you'll see a normal and you'll see a PVC. This is called bigeminy. Bigeminy. When you have the two pairs. And if there was two normals and a PVC, that would be called trigeminy. And if you had three normals and a PVC, that's quadrigeminy. That's all you have to know about that. I know it sounds confusing, Anybody know what page that's on in your book? There's pictures of it, I believe.
Page 75.
Let me check that. That's way back there in 75. Huh?
Yes.
Yeah, I see it at the bottom. But are there pictures of it? Yeah, I see 76, right? Would be pictures. Yep. So that's kind of simple. You know, once you get this down, it's just the name of it. It's nothing. You don't have to know anything else about it. And see, this again is just bigeminy, right? This is bigeminy. So look at page 76. You'll get an idea of what the rest. Because here it is in words. Of course, you need pictures though, because you have bigeminy, trigeminy, and quadrigeminy. So it's the ratio of normal to PVC. But as long as you know it's a PVC, and it does go back to normal for a few beats and quadrigeminy and 1 beat for bigeminy. It's all not normal, right? So now we're going to look at EKGs that show pacemaker spikes. They're not part, it's basically an artifact really, but it's there for a reason. So that is an implantable, automated implantable cardioversion device or pacemaker device. You could have both. You could have a defibrillator put subcutaneous like this. It's like metal, like sort of on the X-ray. Yeah, this is an X-ray or ultrasound. No, this is X-ray. Wow, that's really, no, this is the CAT scan. Sorry, that's really good. I've never really looked at this. You really see the device, the implanted device. So this is what you need to know. Like the one on top, you see the spikes? Yes?
Yes.
So this one is a fixed atrial pacemaker because it's coming before every P wave, not before the QRS. So it's fixed, it's not changing. Like the one on the bottom is a fixed, on the bottom of that is a fixed ventricular. And that's coming every time. There's no P wave here, but it's coming before each ventricular beat or depolarization. The next one down is a fixed dual chamber. Pacemaker. So now you see every time there's two spikes, one in front of the P and one in front of the QRS complex, no matter what the QRS complex looks like. This is a good practice for you to see that these are QRS complexes and P waves. So this is a fixed dual chamber. The one on the bottom is called the demand ventricular pacemaker. So it's not coming at every ventricular beat. Like this is a ventricular beat here too without a spike. So it's only coming on these really wide erratic QRSs. Maybe one here too. So this is a demand ventricular pacemaker. And you could have a demand dual chamber too, and you could have a demand atrial pacemaker. Just said my internet is unstable. Well, the professor's unstable. Of course, the internet's going to be unstable. So here's the I guess choices. It could be fixed, or it just fires every time, or it could be on demand or demand, where it fires when it needs to. And here's the choices: atrial, ventricular, dual chamber. And it could be a fixed rate or variable rate. Of course, the variable rate is still kind of fixed. You know, they could vary it based on the telemetry, what they saw in the EKG. But for you, just know fixed versus demand and atrial, a ventricular, or a dual chamber. And that's where you're going to live.